Hello there, everybody. Thank you guys for being here today. So today we are going to talk about the management of hip labral tears and femoral acetabular impingement syndromes. We're going to look a little bit at like how those two things are separate, how those two things work together, and then what are the conservative and also the non-conservative or surgical management of those positions. And we're going to start off with a little bit of kind of a background anatomy view of the hip and the hip capsule. And Raman is going to be presenting that to you guys.
All right. Thank you so much, Ian. I truly appreciate the opportunity. So let's start with the structure at the center of today's discussion, the acetabular labrum. So if you look at this image on the right, you can see this blue ring of tissue surrounding the socket of the hip joint. And that ring is the labrum. Anatomically, it is made of fibrocartilage and it is almost like a gasket-like seal around the femoral acetabular joint. So that seal is important because it maintains that suction effect between the femoral head and the acetabulum, and this improves joint stability, especially during dynamic movements like running or pivoting. Histologically, the labrum is composed of type 1 and type 2 collagen, giving it a combination of tensile strength and resistance to compressive forces. Functionally, as you see noted on the slide, it participates in proprioception, helps distribute forces across the joint, and contributes to smooth lubrication of the hip. In addition, damage to the labrum disrupts the pressurized system of the hip joint. Damage leads to disruption in mechanical forces, gait, hip, range of motion, and just like patient lifestyle, and ultimately increases, risk for like a secondary hip joint pathology. And so this picture here is not just like a passive ring, right? It's a highly functional structure essential to hip health. And now that we've defined the labrum, let's zoom out a bit. Let's take a look at the broader hip capsule and key ligaments that stabilize it. OMS-I, we just saw these, so it's a good review. And so like on this left-handed diagram right here, you see the three major stabilizing ligaments color-coded. Let's start with the iliofemoral ligament. That's the strongest ligament in the body. It's here in orange. It primarily resists external rotation and anterior translation, especially in flexion. The pubofemoral ligament right here shown in green, that helps limit external rotation, particularly during extension. And then the ischiofemoral ligament, which is right here marked in purple on the posterior view, it's going to restrain that internal rotation, especially during combined flexion, adduction, and internal rotation. All right. Um, Also, one thing that we want to note is when we see the femoral head, you can see that it's enveloped. It's forming a strong capsular envelope with these ligaments. So together with the labrum, these ligaments that we just talked about, they form a dynamic stabilizing system almost, and it's guiding and restricting motion depending on the activity that you are performing. All right, so let's talk about blood supply. This is essential to understanding why labral injuries heal slowly. So, on the right side of the slide, the vessels are labeled numerically. The hip capsule receives branches from the superior gluteal artery and the inferior gluteal artery, and these are in the greater sciatic foramen. If it's above the piriformis, it's going to be that superior gluteal artery, and if it's going to be below that piriformis, you're going to have that inferior gluteal artery. We also have the medial circumflex femoral artery. We have the lateral circumflex femoral artery, and then we have the retinacular anastomoses. So the medial circumflex artery is particularly important clinically because it is the major supplier of the femoral head. But focusing specifically on the labrum, histologic studies have shown that Its vascularity primarily comes from the superior and the inferior gluteal artery anastomoses. This small intraoperative photo right here at the bottom shows the actual terminal vessels entering the labral tissue. And this highlights how limited and delicate the blood supply really is. This reduced vascularity is one reason labral tears often require surgical intervention rather than just relying on some spontaneous healing. And then let's move on and we'll talk about some innervation of the hip capsule. So this can explain why the patients can have deep groin or even lateral hip pain with small labral lesions. The hip capsule receives sensory input from several nerves, including the femoral nerve, the obturator and accessory obturator nerves, the superior and inferior gluteal nerves, the sciatic nerve, which we've all heard, right, from that sciatica pain, nerve to the quadratus femoris. And so from this slide, one key point I want to emphasize is that the anterior capsule and the anterior labrum have the highest density of nociceptors, as shown by the red zones on the table below. That means anterior labral tears tend to be much more symptomatic. In contrast, the posterior capsule has more mechanoreceptors and fewer nociceptors. So posterior tears, they may cause less pain, but contribute to issues like instability or abnormal proprioception. So across these four slides, we can appreciate that the labrum is not just a passive ring. It is structurally, vascularly, and neurologically integrated part of the hip joint. Understanding this anatomy, it can help us guide both diagnosis and surgical treatment of labral and capsular injuries. All right, I'm going to pass it on to Ian now.
Right, Raman, thank you so much. So before we get into maybe the details about what are the different types of labral tears, what exactly is, FAI, how do these things two come together, how are they different? Let's talk a little bit about the prevalence of these in the general population. Systematic review has shown that in the US population, acetabular labral tears are diagnosed in somewhere between 22 to 55% of patients who report with symptomatic hip pain, particularly in anterior hip pain in the Western world. There is also a very high percentage of asymptomatic tears, and these are shown to be prevalent in both athletic and general populations. And if you take some time at all to go and like dig through the literature, almost every single study that's out there that looks at labral tears has a very high percentage of the group that presents with no pain, but upon taking an MRA or doing other kind of like diagnostic tests, they end up finding that they either have some kind of pathological basis for labral tear, or they at least have some kind of mild tear of the labrum. And so we talked a little bit ago, Raman did a great job talking about the neuroinnervation of the labrum. There's still a lot of debate out there around what exactly is the main culprit of labral tear symptomatic pain in people. Is it this high amount of nociceptor innervation? Does it have to do with the inflammatory cascade that comes from tearing at these structures and causes inflammation in the structures around it? And it seems to be kind of like a mixed answer. It's a little bit different for everybody. We do know that the incidence of labral tears tends to be about double in those born female than versus male, just based off like survey data of those that have had procedures, conservative or not, for labral tear incidence. And in the Western world, interestingly enough, we talked about this a little bit, the anterior superior labrum tends to be the area that is most torn in Western patients. And what makes this interesting is it's not just like symptomatic labral tears, but also asymptomatic. And it's interestingly kind of reversed if you go to non-Western cultures, particularly cultures that have a lot of squatting in the culture. So for example, Japan actually has over 50% of their labral tears in the posterior superior and posterior inferior portions because of the high prevalence of squatting versus sitting and other activities. FAI, which we'll get into a little bit more in the next couple slides, but if you've never heard of FAI, which is femoral acetabulum impingement, there's different ways that this can come about, but essentially it is a mechanical irritation between the acetabulum, or the rim of the acetabulum, and the head or the neck of the femur. And so what we also find is that about 10 to 15% of the general adult population in the Western world has the morphology that's present for FAI. So again, not necessarily symptomatic, which we would actually call FAIS, femoral acetabular impingement syndrome, but that there is this structure of the hip joint that is capable of presenting with these kind of mechanical degenerative forces. Also, we find that symptomatic FAI, or FAI that actually causes pain, tends to be associated with labral tears.
They came to my
Hello, what was that? Oh, sorry. Anyway, symptomatic FAI with labral tears tend to present 90 to 97% of the time. So if somebody does come into your clinic or your office and they have FAI that is presenting with pain, there is a very high chance that there's going to be a labral tear associated with that pathology. So let's now talk a little bit more about the function and the morphology of the acetabular labrum. So what exactly is the labrum of the hip? Well, the labrum essentially functions like the seal, like a gasket on a mason jar. And so essentially what this does, you can see it over here in this image of the labral seal, is it forms a partial circumflex around the edge of the rim of the acetabulum and the hip joint. And this creates a space of high pressure within the actual joint itself. And you can see this little space here that is between the head of the femur and the articular cartilage, the inside of the acetabulum. And it's a little less than 0.5 millimeter of fluid that is actually in this space. And so what the labrum does is that it actually seals this fluid in and creates a high pressure system that is supported by gravity, also by the ligamentous teres and other forces. And essentially, this prevents the wear down of the head of the femur and the articular cartilage of the hip joint from actually rubbing into each other. So it causes it to kind of glide and float in place. As Raman mentioned earlier, the labrum is a fibrocartilaginous structure. And the anterior labral collagen, interestingly, is very different than the collagen that we see in the posterior labrum. And this is another one of the reasons that we see that the anterior labrum in a large part of the world is more susceptible to injury. And so if you look at this second image here below, you can kind of see the difference between the two aspects of the labrum. So on the left here, the left lower corner, we have the anterior labrum. On the other side here, we have the posterior labrum. And notice how we have this parallel running of fibers in the anterior compared to the posterior. So the anterior labrum has a parallel laying of the collagen fibers in relation to the cartilage collagen fibers. And because of this, it actually makes it more susceptible to separating and lifting off. Whereas in the posterior, you can also see this up here in the top right, there's an interdigitation, or kind of a blending of the two collagen types that come together. And this in part makes the labrum more structurally sound in the posterior compartment. So let's talk a little bit about what are some of the causes of labral tears in the hip. And so these are considered to be the 5 most common causes that associate with labral tears. Number 1, which we won't talk about too much today, maybe a little bit, is hip dysplasia. Now, some of you, especially OMS-IIs, we just had a hip dysplasia exam in kids, so you're kind of familiar with that. But we also see this prevalent in adult hip dysplasia as well. And so essentially what we're kind of defining by this is we have a shallow hip socket. So in hip dysplasia, there is a misshapening of the acetabulum itself. Because it tends to be a more shallow socket, the joint becomes more susceptible to dislocation, to subluxation, and to just shearing forces in general. Another thing that we find in hip dysplasia is it also creates more femoral anteversion. And femoral anteversion, if you're not familiar with the term, is essentially kind of a rotation in of the thigh bone and the foot. If you look over here at the left image, both of these are from the International Hip Dysplasia Institute, you'll see here that we have kind of in-towing with femoral anteversion. And this will maybe make more sense when we look at FAI, but one of the issues of FAI is that there is running in of the anterior rim, right, of the acetabulum and the femoral neck or the femoral head. And we tend to have less space at the anterior kind of medial line of the acetabulum than we do at kind of the superior and the posterior aspects. And so when someone is overly anteverted, there's more susceptibility to mechanical pressure between the labrum, the rim of the acetabulum, and the head and neck of the femur. The second most common cause, which is going to be one of our big focuses today, is femoral acetabulum impingement. Trauma, high-speed trauma, particularly in high-impact sports, motor vehicle accidents is a big cause. Ligament laxicity and hypermobility, as we see in those with EDS, particularly EDS type 4, tend to have these issues. And then it also tends to be a natural process of degeneration of the hip joint. And so we see a higher percentage of labral tears in the older population. We also tend to see it in those that have developed osteoarthritis and other kind of degenerative issues of the joint itself. So there's different classifications of labral tear. And what we have here is what we call the SELDS classification scale. And in the SELDS classification scale, the normal scale defines just type 1 and type 2. It's recently been updated or modified, we should say, to include type 3, which is really just a combination of the two. And essentially, we have like two situations here. Type 1 in SELDS classification of labral tears is the tear at the labral cartilage junction. And so if you remember a couple slides back where we have the running of those parallel fibers, in type 1 labral tear, essentially the labrum has lifted off of the cartilage collagen. And so we have a separation of the labrum from the hip joint itself. Type 2, as you'll see, there's tears that are a little bit higher up. These are tears that are intralabral. And so in this type of tear, the labrum hasn't separated from the cartilage of the hip joint. However, the labrum itself has become frayed and has become damaged. And then, of course, in type 3, you'll see that we have a combination of both of these. Over here, we just have an image of the zones of labral pathology. And as we kind of mentioned earlier, the anterior and then sometimes here the posterior aspect, posterior inferior, tend to be the two highest zones for labral tears. And so a tear between zones 1 and 2 is the most common. And then second common is going to be a tear between zones 3 and zones 4. Now, let's talk a little bit about FAI and why is this associated with labral tears? And why is there a 90 to 97% chance that there'll be a labral tear associated with symptomatic FAI? So we have three types of FAI, and very similar to the kind of last system for labral tears, we have a type 1, we have a type 2, and then we have a type 3, which is just a combination of having the other two types put together. And so type 1, or what we call pincer FAI, essentially means there's a deformity of the acetabulum itself. And so if you look over here to this image, in pincer, we have excessive coverage of the acetabular rim. And so you can almost imagine it like the awning on a patio, right? It's kind of like extending and it's hanging out a little bit. And so in this type, when the femur is moved in the hip socket, that rim of the acetabular roof that kind of extends over runs into the neck of the femur as the thigh bone moves. And you can see that over here on the right. The second time, or what we call a CAM FAI, is the opposite. In CAM, the acetabulum itself is a normal shape. However, it's the head of the femur or the neck of the femur that is misshapen. And so in CAM type, we actually have the neck that doesn't necessarily run into the rim, but when we move the thigh bone and the head kind of rotates back in the socket, that abrasion goes into the capsule, into the articular cartilage surface, and then it tends to kind of like lift up the labrum or almost break off the labrum for a type 1 tear and separate it from the cartilage. And then, of course, type 2, or type 3, I should say, mixed, we're going to have both of these present in the hip. Now, depending on what type you have is going to often predict your clinical implications. And so pincer types, as we mentioned, are associated more with labral tears and rim compression. And so over here for the pincer, we have the type 2 tears, right? And these are the intralabral. So actually tearing of the labrum itself. And we can see that here in this image with type 1, that we have this fraying right here around the labrum at the edge of the lip. CAM type 2 is associated with separation between labral and articular cartilage, again, a type 1 tear. And then if we look over here at image B, you can see that separation. So the labrum itself is still intact. It's not frayed. However, there's actually just been a complete liftoff and separation between the two structures. CAM type tends to be associated with more issues than pincer. And the reason for this is kind of multifaceted. One is that because of the way the kind of like raised surface of the aspherical head or the neck goes under the labrum into the hip socket, we tend to also have damage to the articular cartilage, which can lead to what we call chondral lesions, or basically degeneration of the articular cartilage itself. And it can also be a predictor of osteoarthritis in the hip for these patients. While the articular cartilage in the hip itself isn't innervated, damage to this structure can cause an increase in pain in the hip joint itself from receptors in the subchondral bone. And so someone who has this CAM type often tends to present more with symptomatic pain due to irritation of the separation of the labrum, but also irritation of the structures within the hip joint itself. Mixed type tends, as you could probably imagine, to be associated with worse clinical outcomes, and it also is associated with more complex surgical procedures, which sometimes might be not just labrum repair, but actually complete reconstruction of the labrum from an auto or an allograft. So let's talk a little bit about what are some of the symptoms that you might see in someone who's coming into clinic with a labral tear or with FAI. The most common reported symptom is anterior hip and groin pain. Of course, if someone has the posterior tear, then it's going to be the opposite, right? They'll have lateral and posterior hip pain if it's a posterior inferior tear. This pain is not uncommon to radiate, so radiation into the low back, anterior thigh, or buttocks. There's usually a clicking, a popping, or a catching that can be associated with this pain. And often that clicking and popping is associated with hip instability. Because if you remember, when that gasket is broken, we lose that high pressure system inside the joint itself, which can lead to structural issues. Muscle stiffness around the joint tends to be common. Decrease not in just active, but passive range of motion, especially for CAM type. If there's been damage to the articular cartilage, we can see restriction in the passive range of motion. And then the pain tends to also be exacerbated by hip flexion activities. So if someone's a gymnast or a runner or anything that involves like a lot of hip flexion, doing those activities will tend to cause like a deep, dull ache within the hip joint. Now, how do we diagnose labral tears and FAI? It depends on who you ask. Surgeons like to say the gold standard is only arthroscopy, but everybody else also agrees that MRA, or magnetic resonance arthrography, is going to be the gold standard as the conservative diagnostic criteria. So MRA tends to be the only imaging that is actually beneficial for labral tears. The reason for this is that we see a labral tear on an MRA because there is an injection of a radioactive dye into the joint itself. And so the dye is injected into the hip capsule, the MRI is taken, and then we can see here on the right, this is from Radiopedia, you'll see that there is this dye that is leaking out of the torn labrum, right? And so because the seal of the gasket is broken and this leaks out, that is how we're able to accurately diagnose that someone has a labral tear. And MRA is reported to have a 91% accuracy. Interestingly enough, MRI only is effective if there is an effusion in the joint and there's also a labral tear present. To diagnose FAI in addition to a labral tear, X-ray is going to be required. And usually you're going to get AP and lateral, sometimes even oblique views if you're going to be diagnosing FAI. The only 100% accuracy is actually arthroscopy, which we'll get into here in a second. And this is a laparoscopic procedure where they actually go into the joint and see it firsthand. Although, sorry to disappoint all the OMS-IIs who just learned all of our orthopedic tests for labral tears of the hip, orthopedic tests alone have been found to not be considered diagnostic for labral tears. And it's really interesting if you get out there in the literature and you kind of take a look at it. You have tests like, for example, the flexion, adduction, internal rotation test, which is being shown here. This is the one that a lot of us just got tested in our BSA on yesterday, in fact. If you look at the literature, almost all of the tests or the studies of the tests in systematic review are the exact opposite. And so most systematic reviews in meta-analysis end up coming to inconclusivity on these tests. So for example, this test here in some studies is shown to have 100% accuracy. And then in other like high quality broad studies, it actually is shown to be the least effective in kind of versa. And so because there's known to be a high false positive, high false negative rate. And so while these physical exam tests can help you kind of like narrow down your clinical diagnosis, they're not actually considered diagnostic in themselves. Another diagnostic test that is used quite common in the orthopedic world for labral tears and joint injuries is actually intra-articular corticosteroids. Jack did a great job of, kind of getting into the nitty gritty of how these work and what they are in his last talk. And while in his instance, I believe we looked a lot about how they can be used for therapeutic purposes, in this instance, they're mostly diagnostic. And so let's say somebody comes in, you're suspecting a labral or FAI or articular cartilage injury. If you inject corticosteroids intra-articularly and the pain goes away, then it's diagnostic for a intra-articular injury. If you inject into the joint and then there's no change, this is also indicative of the fact that it's probably extra-articular and it might be something more like iliopsoas tendinitis, trochanteric bursitis outside of the joint that's causing the issues. This is a list of what are considered the most common differentials that present with the same pain patterns as a hip labral tear. And it looks like there's a lot of them, right? So we won't spend too much time on them, but some of the most common ones are contusion, which is bruising and swelling around the joint from trauma, iliopsoas tendon strain, particularly because of the way that that tendon runs directly in front of the joint anteriorly as it makes its way down to the lesser trochanter. Athletic pubalgia, which is also known as a sports hernia. And don't let this confuse you. It's actually not a true hernia. This is where there is a tearing of the muscles in the deep inner groin, and it mimics pain that's similar to that anterior hip and groin pain we see with labral tears. Osteoarthritis, of course, this can cause labral injuries. It can also be a secondary cause from the original labral injury. Septic arthritis, piriformis deep gluteal syndrome, snapping hip syndrome, which causes that clicking and that popping, sometimes with pain, sometimes without, bursitis, avascular necrosis, or a death of the bone at the head of the femur from lack of blood supply, different types of fractures, dislocation, subluxation, bone tumors, inguinal femoral hernias, slip femoral capital epiphyses, which for those of you who haven't learned about this yet, it's only in adolescents and younger individuals, but it's essentially where the epiphyseal growth plate, which we can't see here because this is an adult X-ray, has separated. And so we actually have a posterior shift of the neck of the femur and the rest of the thigh bone back. leg calf Perth syndrome, which is a PED syndrome of avascular necrosis, and then referred pain, lumbosacral and iliac sacral regions. And so not uncommon to get visceral somatic or somatico-visceral referring from other areas that can mimic labral tears. Let's talk a little bit about the non-operative managements. And so non-operative management of labral tears and FAI tend to come down to reducing the activities that cause the issues, strengthening the musculature around the joint, and then symptom control for pain management. And so activity modification, because flexion-based activities tend to be the ones that cause the most issues here. Getting rid of flexion in your activities tends to go a long way for people. Not uncommon that if someone has a labral tear, the first couple of weeks, if it's bad, they may actually have this person on crutches. You're going to avoid sitting for long periods of time because even that is kind of a flexion-based posture. You'll avoid putting weight on the foot because you don't want to pivot or twist on that leg while that leg is planted. And then basically we're just giving time as we do activity modification to perhaps reduce inflammation, reduce swelling as a result of injury to those structures. Physical therapy usually starts with strengthening the hip musculature, right? A lot of people on hip abductors and external rotators. You may remember a couple slides ago, we talked about that anteversion or that kind of in-toeing that can happen of the femur with hip dysplasia. We can also see that when someone has a weakness in their hip abductors and their hip external rotators. And so if someone has very tight adductors or hip flexors and weak glutes or weak posterior chain, it can cause kind of an inward rotation, which can exacerbate pressure in that space. It's very common for injuries to the labrum. Core strengthening to increase posterior pelvic tilt and reduce the pressure at the anterior hip joint. Neuromuscular training has been shown to help in recovery of athletes. And so essentially training like musculo-firing patterns has been shown to be helpful. Retraining gait and then stretching and soft tissue manipulation around the tight musculature has also been shown to be beneficial. For symptom control, we already mentioned the corticosteroids, right? What's different here with this, maybe compared to like osteoarthritis or some other, degenerative injuries, is that it tends to be helpful for the symptoms in the short term, but because this is the degradation of mechanical tissue, the symptom relief is usually short-lived for most people. And so the main symptom controls tends to be NSAIDs, acetaminophen, corticosteroids if it's very mild, or perhaps we're trying to like off-put surgery for a specific amount of time. Another that is very common, and I saw this a lot when I was doing an internship this summer at an ortho clinic, is intra-articular hyaluronic acid. And essentially what the hyaluronic acid does is it mimics the lubrication of the joint space. And so you can use this in a couple different pathologies, but it essentially is like the corticosteroids, and it puts off surgery for perhaps a longer period of time because it gives just a little bit of a smoother glide to the joint and the socket. Something that I found very interesting is that conservative treatment plans have been shown to have higher success rates across the board when patient education is initiated prior to rehabilitation. And I find this really interesting for a lot of us as future clinicians, as just a reminder that, when you inform patients about exactly what's going on, kind of include them in the game plan and in their treatment, they tend to have better outcomes, which, who'd have thought? So let's talk a little bit about the surgical management. And surgical management, for the most part, is not necessarily the gold standard. I don't think gold standard is the right term for dealing with labral tears and FAIS. But most people, even if they do conservative treatment, do at some point end up having surgical management for this procedure or this pathology. And so hip arthroscopy is the gold standard of surgeries for labral tears and FAIS. There are three main surgical routes that you can go in hip arthroscopy for labrum, and that is either debridement, labral repair, or it's labral reconstruction. If you're not familiar with what debridement is, essentially debridement is where they go in and they clean out the damaged tissue. So let's say you have a very mild tear and you just have like slight fraying that's causing an inflammatory cascade or some kind of irritation. They'll just go in and they'll clean up a little bit of that frayed portion. They'll shave it off, but they won't actually like suture or do any repair to the remaining labrum itself. Pincer FAI has a higher association with labral repair and reconstruction, and mixed type is the highest associated with full labral reconstruction. And so over here is just a little bit of a breakdown of like a simple list of indications for debridement or repair versus construction. And we'll get into this a little more in the next slide as well. So indications for debridement and repair, usually shorter duration of symptoms, so weeks to months. Once somebody starts to get into longer duration, like chronic labral tear symptoms that have been happening for a year or more, we start to consider reconstruction of the labrum. Coexisting pathology is a likely pain generator. And so if there is an indication that some of their issues are labral related, but then some of them are also maybe from bursitis or from iliopsoas strain or something else, we'll usually start with debridement. Being younger than 25 years old is also indicated for a less invasive procedure, and mild intrasubstance tearing. And so once we get past mild intrasubstance, we're pretty much looking specifically only at reconstructions here. And in contrast, when we're looking at like, when do we indicate specifically a reconstruction, severe pincer type or chondrosis. So once there is degradation, mild or severe, to the articular cartilage, we start to consider reconstruction. Older than 35 years, moderate intrasubstance tearing or severe labral damage, ossified labrum, collagen disorders, or if they've had a previous debridement or repair that has failed, then usually the next step is going to be reconstruction. So most of us are probably already familiar with like, what is arthroscopy, right? But in case you're not, just a quick kind of brief overview is that arthroscopy is a procedure that is a laparoscopic procedure. And essentially what they do is there's a couple of ports that are created at different areas around whatever joint you're going to work on. For hip labrum repairs or hip capsule in general with arthroscopy, we tend to have three standard ports. That is the anterior port, the anterior lateral portal, and then we also have the posterior lateral portal. There are significantly more of these depending on who you hang out with, but these are the three standard ones that tend to get used by just about everybody. And then we have traction of the surgical leg to slightly displace the joint, right? And this creates a little bit of space for us to look into. And then as you look down here, you'll see a couple different devices, right? And so we have our arthroscope, which has a camera inserted through the cannule, which is basically the portal that is like a little metal tube, almost like a metal drinking straw that the scope goes down through. We have another port here that controls the water force or the pressurized pump system that we use. And then we also have whatever device is going to be used for shaving the bone or suturing or vice versa. And so in arthroscopy, what makes it different than some other laparoscopic procedures is there is a pressure-controlled saline solution that flows through the system. And so this increases the visibility, it widens the tissue, it removes debris, and it also helps control bleeding, which is very helpful. And interesting for arthroscopic surgery, decision on what treatment is going to be used is often made at the time of the procedure. And so whether or not, because if you remember, arthroscopy is the only thing that really has 100% accuracy, they might go in thinking they're going to do a reconstruction and then get in there and realize, oh, actually, this is just going to be a minor repair or vice versa. And this is just an illustration of what you usually see through the scope. And so here you'll see that we have AC is the articular cartilage, FH is femoral head, and then L, of course, is labrum. And one of the first things they do when they get in here with the probe is they test the labrum for what they call viability and stability. And so if the labral is stable, it tends to not fray, it tends to not separate from the articular cartilage. And then if it's viable, it's a sign that the labrum still has the potential to be repaired versus needing to be reconstructed. So this is just a little video of an arthroscopic technique. I don't know if you guys can hear it, but at the very least you'll be able to see it. So you'll see here, I don't know if you guys can hear the volume or not, but what we have is we have the scope, we have the shaver, and then you'll see here that in this labral tear, they create a little bit of a removal from bone. There's a suture that is placed around and underneath the labrum. And then from here, you'll see that they go through the procedure of suturing and readhering the labrum back to the articular cartilage. And so this would be an example of arthroscopy repair for a type 1 labral tear specifically. And if the tear was worse, we would go and we would continue around the labral attachment until it was resecured. So this is a list of some of the common hip arthroscopy procedures, because often when you have hip arthroscopy for labral repair, it's not simply the repair of the labrum that is necessary, because remember, we have FAI, we have the overgrowth of the acetabular rim, we have the overgrowth of the femoral neck, and then sometimes we have damage to the articular cartilage. And so when those things happen, we also have to, be prepared to deal with those issues. And so the first three we've already kind of talked about, right? The labral debridement, labral repair, and labral reconstruction. And then femoroplasty and then acetabuloplasty. Oh, sorry, it's a hard word for me. These are the two types of procedures that we use to deal with FAI. And so essentially, for when we're dealing with the acetabulum, this is going to be for the pincer type, right? And so a plasty, if you're not familiar with the root here, is essentially going to be the removal of bone. And so for this procedure, the technique is reduction of the acetabular rim. For the femoroplasty, it's just for the cam type, and it's a reduction of the femoral neck. And then the last three here deal with chondral lesions, or when there's been damage to the articular cartilage. And there is a grading scale that I didn't include in here for chondral lesions. So if you're interested, feel free to look that up after we're done. But essentially, a chondroplasty is indicated for mild chondral lesions. And kind of how we do labral debridement, this is debridement of the actual lesion that's present within the articular cartilage itself. Microfractures. This one, I think, is one of the coolest procedures that they do for hip arthroscopy. And I think it's also really prevalent for knees. But essentially, what a microfracture procedure is, and it's done for mild to moderate chondral lesions, is they do perpendicular drilling into the articular cartilage itself. And what happens is this causes marrow clots to flow out of the bone and essentially fill these lesionous holes or these lesionous gaps. And then the differentiation process by the chondrocytes leads to cartilage preservation. It's a pretty cool, and also considered one of the cheapest arthroscopic procedures for damage to the articular cartilage. Last, which is kind of a newer procedure that's taken root in the last 10 years or so, is autologous chondrocyte implantation. And this is reserved specifically for moderate to severe degeneration of the articular cartilage. And essentially what they do is they harvest chondrocytes from your body, they take those out and they cultivate them in vitro, and then they go back in, they clean up the lesion, and then they implant these cultivated cells into the lesion to attempt to regrow the articular cartilage site. Implications of arthroscopy tend to be mostly associated with intraoperative complications statistically. And so intraoperative, the labrum and acetabulum during the procedure itself. So perhaps there ends up being more damage caused. Injury to the neurovascular structures. So of course we have the femoral neurovascular bundle. There has been instances reported of lateral femoral cutaneous nerve injury, and also very rarely the gluteal nerves and sometimes a sciatic nerve, but this is less than 1% that we see this complication. Traction injury, which tends to be the most common because they have to traction the thigh bone out of the hip socket to be able to get in there to repair these structures. And about 7% of procedures are reported to have some type of traction injury. And sometimes this presents as femoral nerve palsy. Sometimes it prevents as soreness in the muscles and instability, but most of these do tend to go away over time. And in arthroscopy in particular, what's interesting is that there's a maximum limit of 2 hours of traction of the hip joint for these procedures. And so it's considered kind of like once you get past 2 hours, the risk of traction and damage to the hip tends to outweigh the actual healing and repair process itself. So you try to do them under that time limit. Of course, damage to the articular cartilage, poor osseous reshaping, which is really just error on the part of the surgeon. Maybe they didn't do a great job completely, removing the FAI impingement. And then we also have fluid extravasation. And fluid extravasation is essentially where the saline solution that's being pushed in through the leaks into another part of the body. The most serious, and this tends to happen with more invasive procedures where they're removing more bone from the pelvis, is it actually makes its way into the abdominal cavity, which can become an emergency situation if that's the case. Other complications, which are more post-op related, in early post-op, of course, infection is always something that we look for. DVT and instability of the hip joint. Late post-op complications include avascular necrosis, scarring adhesions, heterotropic ossification, so essentially ossification of the labrum from the procedure, fractures of the femoral neck, and then bursitis, the trochanteric fan. This tends to be a relatively affordable procedure for the most part. And so there are common criteria that most insurances across the board require for hip arthroscopy labral repair. The first is that they tend to all require an MRA confirming the tear. They require documentation of the FAI, which is going to include x-rays, it's going to include physical exam tests, et cetera. Most insurance companies are going to require at least 6 weeks of conservative management before surgery that has shown no improvement. There needs to be symptoms that are affecting function. So if you have a labral tear discovered on a MRA or another diagnostic image accidentally, but you have no symptoms, you're going to have a hard time getting this covered. And then no advanced osteoarthritis, because this has been associated with worse outcomes from labral repairs. And so often insurance will refuse to pay for a labral repair if you have severe OA. If you do choose to pay for it yourself, it tends to run from about $6,000 to $15,000, depending on what state you live in and what type of repair you're going to end up needing. Conservative management tends to be cheaper. However, data has shown that there's a higher quality of adjusted living from long-term outcomes in arthroscopic repair, despite the initial higher cost. And so essentially, those who do go through arthroscopic repair report having less pain and the more ability to live their lives as they choose long-term than those who choose conservative management alone. Since 2011, we have seen about 85% of increase in hip arthroscopic labral repairs, and this comes straight from the U.S. National Database of Orthopedic Insurance Records, and it also includes all hip procedures that have been recorded through Medicare. And it's thought that this has to do with better diagnostic imaging technology. Laparoscopic and arthroscopy procedures have been around longer, so we have more surgeons who are much more adept in them than maybe they were 10, 15 years ago. And we also find that there tends to be those who prefer surgical treatment tend to be those with active lifestyles. The reason for this is that conservative management of labral tears and of FAI can be very effective, and it can help with managing your pain. But one of the caveats that comes with that is more or less giving up the activities that have caused this injury. So if you love to hike and this was your main activity that exacerbated this issue, you love to play sports, you love to run. Conservative management, for the most part, won't allow you to continue doing those one day, but instead it requires you to give up those activities to reduce inflammation and reduce irritation. So those with active lifestyles who choose to return to whatever they were doing that caused the injury tend to prefer going with the surgical treatment option. And years of benefit and patient quality of life should always be considered as a clinician when you're trying to decide should someone stay with the conservative management route or should they go the surgical route. So let's talk a little bit about research and gaps in the literature. We're just about at the end here. I appreciate you guys sticking with me. And so when I was going through the literature, a couple things that I noticed is big gaps, and also kind of had AI look through to see if there was anything that I was missing to back this up, is that there tends to be a lack of high quality comparative data on pain severity between the different types of FAI. So essentially, most studies describe the patterns of the cartilage labral damage, but few quantify the differences in pain, functional scores, or quality of life across FAI subtypes. And there's been no meta-analysis or systematic review to date that has actually put all these pain scores together and seen what is the correlation between these, how do we compare these different pain scores, maybe as a group rather than individual systems. And so proposed literature review topic might be symptom severity across CAM, pincer, mixed femoral acetabular impingement, systematic comparison of patient-reported outcomes. Another one, poor standardization of radiographic and MRI diagnostic criteria. And so essentially, almost all studies out there have their own criteria for how they diagnose these with their MRAs and their X-rays and all of the different angles that they measure of the acetabular joint and the depth and the femoral head. And so there's really no meta-analysis out there that looks at all of these and then has standardized what are the variables that maybe everybody should use across the board. Last one, lack of high quality comparative data for conservative treatment effective for hip labral tears. I actually think this would be a really easy one to do a systematic review or a literature review on, because there's been no high quality systematic reviews in the past 20 years that look at the effectiveness of conservative treatment across the board for these issues. And so since there's no large body of evidence that does this, there is a large body of evidence to pull from on these different approaches. And so there's tons of random control trials, cohort studies, case reviews, PT protocols that talk about different conservative treatments, but no one has put them together to kind of look at bigger trends. And yeah, no unified review comparing all non-surgical approaches across the board. And that's all I have.